بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good day for you all. Today we will be talking about hemoptysis, which is a very significant symptom and one of the cardinal symptoms in the respiratory tract. And you may face patients who present with hemoptysis in different places, mainly in the emergency room, but sometimes you will face them while the patient is in the hospital already, or sometimes they come to the clinic or to the office complaining of hemoptysis. So let's start by defining hemoptysis, which is a coughing up of blood that's frightening to both the patients and their families as well as to the healthcare providers. And the reason why it's frightening, it's multifactorial, and to the patients, it's sometimes mysterious. It may originate from the sensation that you are bleeding from a vital organ, which is the lung, compared with less frightening sensation that occurs with bleeding from other sites. If you want to define hemoptysis, it's the expectoration of blood that originates from the lower airways and the lungs. Anything above that is not considered a true hemoptysis, although it may be mistaken as hemoptysis. The patient may present with blood-streaked sputum or pink sputum, or may present complaining of coughing up a frank blood, which can be bright red or can be dark, and can be associated with clots or without clots. And to understand this symptom, you need to go back to your basic physiology and anatomy. If you remember that the blood circulation in the lungs has two components. There is a high pressure circulation, which is the bronchial circulation, in which the pressures are equal to the systemic pressures. And here the vessels, the bronchial arteries and their collaterals originate from the aorta, and it's the source of bleeding in most cases of massive hemoptysis. I should add most cases of massive hemoptysis. While the pulmonary circulation, which is a low pressure circulation, which rarely is a cause of the massive hemoptysis, usually patients with normal pulmonary artery pressure has no or who do not have pulmonary hypertension bleed rarely, and it can be sometimes responsible for massive hemoptysis, but this is only a minor fraction of the patients. So what are the mechanisms that cause a vessel to bleed? It occurs either due to the erosion of the blood vessel or the vessel wall in the presence of an inflammatory condition, or it may occur due to the rupture that occurs acutely due to increased pressure in the vessel, or it can occur chronically after aneurysmal formation that results from a chronic increase in the pressure of the vessel. The severity of this condition is determined not only, as with any bleeding, with the amount and the rapidity of the bleeding, but it's determined also by the effect on the gas exchange and the cardiopulmonary reserve of the patient, or cardiorespiratory reserve. That means his baseline cardiac status and his baseline pulmonary status. In the literature, there is a wide variety of reports that talk about massive hemoptysis. Massive hemoptysis, the hemoptysis that threatens the life of the patient. Some reports or some literature reports as low as 100 cc per 24 hours. Some reported more than 1000 cc per 24 hours. So it's not, and there are other reports that talk about 250, 500, 600, 700, etc. So it's not the amount of blood alone that determines whether the hemoptysis is severe and massive and life-threatening. It is the flooding of the tracheobronchial tree that may lead to respiratory arrest due to asphyxiation rather than exsanguination that may lead to the seriousness of the condition. It is usually a medical emergency when it's massive. Unfortunately, if you talk about all cases of hemoptysis, it occurs only in 1 to 5% of the patients. But we frequently see this, and we have to know how to manage the patients who present with hemoptysis, whether it's massive or not massive, non-massive, because non-massive hemoptysis can at any time turn into a massive and life-threatening hemoptysis. So the first step is to make sure that the patient is complaining of hemoptysis. Patients sometimes can confuse hematemesis or epistaxis or bleeding from other nasopharyngeal bleeding, post-nasal drip of blood and coughing up blood with hemoptysis. The most important thing is to take a proper history. The presence of chronic lung disease, the presence of shortness of breath and respiratory symptoms can point that the problem is hemoptysis. Presence of GI symptoms, nausea, vomiting, presence of pre-existing gastric or hepatic disease, especially esophageal varices, can point that the patient is complaining of hematemesis. Pre-existing forceful vomiting may also point to an esophageal tear and hematemesis. In the past, we used to examine the sputum and to measure its pH and look at it under the microscope, but we rarely need to do this if we take a proper history. Now, while taking the proper history, we need to decide what's the etiology of this hemoptysis, because this will help us to manage the case. We can classify hemoptysis according to the site. Patients may bleed from their tracheobronchial tree, as in bronchitis, bronchiectasis, and bronchogenic carcinoma, which are common. And uncommonly, patients may have airway trauma or presence of foreign body, which we see sometimes in pediatric age group. Presence of a rare disease, which is bronchiolithiasis, can also be responsible for hemoptysis. The pulmonary vessels can be also responsible for hemoptysis. We see this sometimes with cases of acute pulmonary embolism. And we see this with less common conditions that can cause hemoptysis, like arteriovenous malformation and pulmonary hypertension, with its two types, arterial or venous. And sometimes it's iatrogenic. It occurs while we are doing pulmonary artery catheterization, and rupture can lead to hemoptysis, but those conditions are very rare. Pulmonary parenchyma can be responsible, and the biggest examples are TB and pneumonia, as well as lung abscess. Sometimes you are faced with other conditions that are less common, like mycotomas, Goodpasture syndrome, Wegener's granulomatosis, lupus pneumonitis. Sometimes patients with idiopathic pulmonary hemosiderosis present with hemoptysis, and lung contusion, like we talked about airway trauma. Trauma can lead to a contusion of the lung parenchyma, and this can be a source of bleeding. Sometimes it's difficult to point to a certain site. The cause is systemic, and this occurs in systemic coagulopathy or use of anticoagulants or thrombolytics, and sometimes it's an extrapulmonary source that manifests as a pulmonary manifestation, like pulmonary endometriosis, and this can be parenchymal or tracheobronchial. Now, talking about the site sometimes is confusing because it makes the rare, the common, and the uncommon conditions. If you want to think of hemoptysis according to the commonest etiologies, you should think of one of 5, which are the bronchitis, bronchogenic carcinoma, bronchiectasis, pneumonia, and tuberculosis. And what is common depends, what you think is common depends on the population you are studying. However, you should also keep in mind that other etiologies exist, and the history will lead you to what is the etiology of the hemoptysis. The incidence and frequency varies according to different studied populations, and a certain etiology may reflect the incidence of that disease in certain population. I'll give you two examples. Population who have common or endemic TB, you will find that TB is common cause of hemoptysis in that population. Population of smokers who are especially males and above 60s, you find that bronchogenic carcinoma is the most common. So you should think of the etiologies according to the population you are dealing with. This is an example of certain population. As you see, neoplasms or lung neoplasms are common. Bronchitis is common also, and there is a lot of miscellaneous causes which are other than the other etiologies: bacterial, pneumonia, tuberculosis, and bronchiectasis. And don't forget, in some cases, the cause remains obscure. We call this cryptogenic hemoptysis, which is defined as hemoptysis despite all the workup that you are doing, all the history and physical, you fail to reach a certain diagnosis. Now, your approach to the patient with hemoptysis is history and physical examination first. And there are certain clues that you can find that point to a certain etiology, and we will talk shortly about those. You need, during the history and physical examination, to assess the severity and urgency of the condition, the duration of this includes the duration of the bleeding, the amount or the extent of the bleeding, and the reliability of the patient. And here we stop about the reliability, because we are not saying that the patient is not reliable, but the patient may subconsciously exaggerate the amount of bleeding, because, as I said, it's life-threatening. One or few drops of blood on the floor that can make a large circle can be translated by the patient as a massive bleeding. And we had such a condition. Even it fools the medical resident who was dealing with the patient. The patient has like 200 cc of, 20 cc of bleeding, and the resident was thinking that it's 200 cc, and he started to deal with the condition as such. You need to assess the cardiopulmonary reserve, whether the patient's having previous cardiac or pulmonary conditions, as we said, because this has a lot of impact on the management. And you need to ask about prior episodes of bleeding. Now, when you are taking the history, patients who have blood streaking of mucopurulent or purulent sputum, whether it's acute or chronic, this can point to a bronchitis, acute bronchitis or chronic bronchitis. Patients who have chronic bronchitis can have recent change in the quantity or appearance of the sputum on a baseline chronic sputum production. Then you may think of acute exacerbation of chronic bronchitis or COPD. If there is fever, chills with the presence of purulent sputum, you will think of pneumonia. And lung abscess can be considered if the sputum has a putrid smell. While patients with who present with sudden presentation of chest pain or sudden shortness of breath associated with hemoptysis, you may think of PE. Those are just examples, and don't forget the bronchiectasis, in which the patients present with copious secretions and history of recurrent infections, You will have a separate lecture about bronchiectasis, but don't forget that they have characteristics, CT scan, high resolution CT scan appearance that points to the diagnosis. Sometimes certain risk factors will lead you to think about certain or will give you a clue to a certain condition, like smoking or working with asbestosis points to bronchogenic carcinoma. The presence of risk factors for lung abscess like alcohol, coma, and poor dental hygiene will lead you to think about lung abscess. And this also applies to the risk factors for HIV. That includes drug abuse, history of blood transfusion, deviant sexual practices. Sometimes history of previous or coexisting disease also may lead you to the diagnosis. History of renal disease, you may think of good pasture and Wegener's granulomatosis. For examples, there are a lot of diseases, but those are examples. SLE with hemoptysis, you can think of lupus pneumonitis. Patients with history of malignancy, whether it's primary lung malignancy or metastatic lung or metastatic disease, you think of this as a cause of the hemoptysis. Endobronchial Kaposi carcinoma, Kaposi sarcoma, sorry, can be present with AIDS. And the history of previous bleeding usually points to an anatomical lesion in the lung, but you should always think if there are previous bleeding and no previous lung disease of a bleeding diathesis, use of anticoagulants and thrombocytopenia. Now, the clues which we just mentioned are just examples. This table entails more detailed clinical clues and suggested diagnosis for those conditions. We'll go just about a few of these, like for example, if you have a patient with history of association of hemoptysis with menses, this is, we call it catamenial hemoptysis, and occurs with endometriosis. Patients who have history of immunosuppression, you should always think of tuberculosis and HIV. Patients who have a travel history, you should think of certain microorganisms according to the area he travels to. When a patient has history of weight loss, you should think of malignancy as well as tuberculosis and chronic infections. Patients who have history of pleuritic chest pain, history of leg swelling or tenderness, you may think of DVT, pulmonary embolism and pulmonary infarction, etc. So there are a lot of conditions that you can, in the history, get clues about, and those clues also are age dependent. Sometimes certain age will lead you to think of a certain etiology. Physical examination as well can also give you clues to the conditions that may be causing hemoptysis, and you should always do proper physical examination for a patient who presents with hemoptysis, because the clue can be present in the chest and can be present in anywhere else in the skin, central nervous system, the abdomen, the head and neck, etc. I'll give you a few examples, and you can read this table more extensively. Like patients who present with gingival thickening or saddle nose, you may think of Wegener's granulomatosis. Of course, you know the differential diagnosis of clubbing, and a patient who presents with clubbing and hemoptysis, you should think of conditions that cause this combination of symptoms, and on the top of those are lung cancer and bronchiectasis. Of course, lung abscess chronic lung abscess can cause this. If a patient who has telangiectasias, you may think of the rare Osler-Weber-Rendu disease, especially if those telangiectasias are associated with epistaxis and they are present in the orofacial mucous membranes. So you can go over the table and get more clues. The thing that you cannot go into the details of all those diagnoses, because this is medicine. While you are reading in your internal medicine, you will find those combinations, and common is common. We are talking about the common things. After taking the history and doing the physical examination, your goals are to identify the cause, localize the site of the bleeding, and assess the general condition of the patient. Of course, the basic thing is to do labs, and those labs include a complete blood count, coagulation profile, sputum studies and cultures. Sometimes you may need to do kidney function, urine analysis, and collagen vascular studies. All of those can lead you to a diagnosis, but also can give you an insight about the complications of hemoptysis. Of course, you need in certain conditions, if the patient is having massive hemoptysis, to get a blood gases, even if the patient is not hypoxic, with the pulse oximetry, because the condition may deteriorate at any time and you will need a baseline blood gas. And after that, you will go to the radiologic studies. Of course, as we said in the history and physical, there are certain laboratory findings that you can, when you find them, you have a relation to the diagnosis by some clue that will point. That's why we do the labs, because they help us also not only to evaluate the extent of the problem, but to point to a certain diagnosis. Example طبعا زي ما حكينا مثلا collagen vascular studies, PPD, HIV testing, blood cultures, كل هاي الأشياء they point to a certain aspects in the management of hemoptysis. Now, the chest X-ray should be done in patients who present with significant hemoptysis. Sometimes patients who come to the emergency room with findings suggestive minimal acute bronchitis, very transient hemoptysis, you do not need to do chest X-ray, but in most cases who have more significant bleeding, you need to do a chest X-ray, even if it's normal in up to 30% of the patients. And the other drawback is that the abnormality that you can find in the X-ray may not reflect the exact site of the bleeding. And this is for two reasons. First, there are blind areas in which you cannot see in the X-ray. And second thing, blood is a fluid that moves with the gravity. So the blood may move from one side to another, and you will it may accumulate according to the position of the patient. So you will find, you may find an infiltrate that does not reflect the exact site of the bleeding. We need to do, in some cases, a CT scan, and we decide the CT scan according to the type. I mean, we decide the type of the CT scan according to the diagnosis we are suspecting. If you are suspecting pulmonary embolism, you need a CT scan with contrast and pulmonary embolism protocol. If you are suspecting malignancy, you need a CT scan with contrast. But if you are suspecting bronchiectasis, you may need high resolution, or parenchymal disease, you may need high resolution chest CT. And in bronchiectasis, as you will see in the lecture of bronchiectasis, now the cornerstone of diagnosis of bronchiectasis is high resolution CT scan. In the past we used to do bronchography, but it's not used anymore. Now, this is an example of a normal chest X-ray in a patient who presents with hemoptysis, and the CT scan showed a lesion in the lung that's behind the heart, and this lesion is a cavitary lesion that cannot be seen in the chest radiograph, but it was clearly demonstrated in the CT scan, and it turned to be a cavitary squamous cell carcinoma. And as we said about the other diagnostic studies, a lot of findings in the chest X-ray or in the CT scan can point to a certain diagnosis. For example, we frequently see cavitary lesions, and cavitary lesions point to either lung abscess, tuberculosis, or necrotizing pneumonia. Patients who present with hilar adenopathy, you can think of lymphoma, carcinoma, TB, or sarcoidosis. Patients who present with emphysematous changes with hyperinflation, you think of COPD. Patients who present with cardiomegaly, you should think of cardiac condition as a cause of hemoptysis, like mitral valve stenosis, etc. So pulmonary infiltrates may point to pneumonia or interstitial lung disease. So you need to think about the diagnosis in the context of the X-ray. Now, in certain cases, the labs and the X-rays are enough to reach the diagnosis, and the bleeding stops, and you need to do no further intervention. You just go and give the specific treatment according to the cause. But in some cases, you need to exactly determine the site of the bleeding because the bleeding is recurrent. And sometimes you may need to do sampling of the lung or transbronchial biopsy. I mean sampling of the fluid by bronchoalveolar lavage, or taking a biopsy. So you may need to go to bronchoscopy. Sometimes the bleeding is massive and you need to suction the blood and to do some therapeutic interventions. So we have two types of bronchoscopy. We have the fiber optic bronchoscopy, which has better visualization, can be done at any place in the hospital. It can be done at bedside of the ICU. In the ICU, it can be done in the bronchoscopy suite. It can be done in the floors if you want. It has better ability to navigate the smaller segments. The problem is you have a lot of, or you have poor ability to suction the blood, and the interventions are limited with the fiber optic bronchoscopy. The rigid bronchoscopy has better blood suctioning and more therapeutic interventions, but the problem needs more skills, needs operation theater, and it needs to be either done by the thoracic surgeon, or you need to have the thoracic surgeon around in case you need to do a surgical intervention. This is an example of a bronchoscopy, a fiber optic bronchoscope, in which we saw a tumor occludes the left upper loop bronchus and actively bleeding. You see this white thing with the dark blue arrow, and around it is the bleeding. This tend to be a bronchogenic carcinoma. You can see also a lot of other findings. We will not go into each specific things, but you may see strictures, you may see endobronchial mass, you may see increased vascularization, you may see white thrush pointing to candidiasis. You can see a lot of findings that are helpful. And if you don't see anything, you take samples that may help you to reach the diagnosis. Now, there are a lot of interventions that also can be done in through the bronchoscopy, for example, ice saline lavage, in which you put ice saline in the area in which there is a bleeding. The problem with this intervention is very temporary and short-lasting. It may help in some cases. It may help as a bridge while you are arranging for other interventions, but it's not that much helpful. And the same thing applies to the topical vasopressors. Now you may do selective intubation and ventilation. And we mean by this, you put a special endotracheal tube, whether single lumen or double lumen, in which you introduce a balloon and you inflate it to obstruct the, you see the blue balloon that obstructs the lumen of the main bronchus of a certain lung, whether the right or the left, and you allow the ventilation of the other lung. And you allow, this allows the collapsed lung to have vasoconstriction and stopping of the bleeding. Sometimes you may do endobronchial tamponade, inserting a certain catheter to a certain segment through the bronchoscopy, and we call this catheter Fogarty catheter. And at the end of the Fogarty catheter, there is a balloon that you can inflate and obstruct the lumen. By this, you isolate the source of bleeding, you allow collapse of that segment or subsegment, and this may help to stop the bleeding. Or sometimes you may need to do for certain ulcer or tumor that's bleeding, a laser photocoagulation. And the other radiologic study is the bronchial angiography. This is an angiography that's done to the bronchial circulation. This is done usually with diagnostic and therapeutic intent, and we will talk about it at the end. Now, the management varies with the severity of the bleeding, the cause of the bleeding, and, as we said, the cardiopulmonary reserve and general condition of the patient. If the patient is having non-massive hemoptysis, that means his vital signs are stable, he's not in respiratory distress, his blood gases are okay, he does not have pre-existing unstable cardiopulmonary conditions, then we monitor until the patient is stable, and we have the luxury of time to find the cause. When we find the cause, we give the specific treatment, whether it's immunosuppressive treatment, antibiotics, chemotherapy, radiotherapy, foreign body removal, etc. While if the patient's having massive hemoptysis, that means the amount is relatively large, and the patient have problems with his breathing, or he has unstable pre-existing pulmonary or cardiac conditions. This is a medical emergency. The patient should be in the ICU always, and the rapidity of the bleeding and the extent of the cardiopulmonary dysfunction dictates the urgency for the management. You should always keep the patient with massive hemoptysis MPO. You put him in the position that has the least chance to bleed. You may give him strong cough suppressant like codeine, and you give him fluids because he's MPO, and sometimes you may need fluid resuscitation if the patient already lost a large amount of blood. You should have a large IV access, and if there is any coagulopathy, it should be corrected promptly, whether by fresh frozen plasma or by other blood products or coagulation factors. The patient should always have ICU monitoring, as we said. The priority is to protect the airway always. If the patient has no threat to the airway, you may leave him without intubation. But if there is any threat that the blood may flood the trachea and may cause asphyxiation, then you should intubate the patient and put him on mechanical ventilation support. As we said, you should stabilize the patient, and then you do all the studies, including the bronchoscopy and the radiologic studies, the lab studies, in an attempt to find the cause or the site of the bleeding, and then the interventions to stop or attempt to stop the bleeding. And by this, you are managing the current situation, but you should always keep in mind that you should have a plan to, if you succeed, to prevent the recurrence of the bleeding and to give a specific therapy for the cause of this hemoptysis. As we said about the interventions that can be done, there are bronchoscopic interventions. Sometimes they do not fail, or they do not succeed, or they fail, and sometimes they are not all available. So you may need to do bronchial artery embolization, as we said previously. In this bronchial bronchial embolization, you will need to do bronchial angiography first. This is done by interventional radiologist, and when the angiography reaches the site of the bleeding, they will clog or obstruct the site of the bleeding by either foam or a coil, and by this they stop the bleeding. And if all this fails, then you may need, if the patient tolerates surgery, to go to lobectomy or pneumonectomy. This is not usually needed. We usually succeed in treating the condition without reaching this stage, but you should keep it in mind in case nothing else works. You should always observe the patient very closely, and we hope that you will not have a problem with a lot of patients who have hemoptysis by following the rules which we talked about. Thank you for listening, and good day for you all.